Hi and welcome back to another video of Medic Notes. This video is on nephrotic syndrome. Nephrotic syndrome is a clinical syndrome defined by massive proteinuria responsible for hypoalbuminemia, with resulting hyperlipidemia, edema, and various complications. It is caused by increased permeability through the damaged basement membrane in the renal glomerulus, especially infectious or thromboembolic. It results from an abnormality of glomerular permeability that may be primarily due to an intrinsic renal disease in the kidneys, or secondary due to congenital infections, diabetes, systemic lupus erythematosus, neoplasia, or certain drug use. Nephrotic range proteinuria is defined as the urinary loss of 3 grams or more of proteins per 24 hours or, on a single spot urine sample, the presence of 2 grams of protein per gram of urinary creatinine. This proteinuria can also result from other systemic diseases, such as amyloidosis. The disorder can affect people of all ages. In most children, the first sign of nephrotic syndrome is facial swelling. Adults usually present with dependent edema. Common primary causes of nephrotic syndrome are intrinsic kidney diseases, such as membranous nephropathy, minimal change nephropathy, and focal glomerulosclerosis. Secondary causes may include systemic diseases, such as lupus erythematosus, diabetes mellitus, and amyloidosis. An episode of infectious diseases, particularly the upper respiratory tract, is a triggering factor in almost half of cases, an allergic reaction in a third of cases, and more rarely, an insect bite or vaccination. Nephrotic syndrome can also result from drugs of abuse, including heroin. Secondary causes of nephrotic syndrome include diabetes, autoimmune disorders, and infections as listed here. Medications may also cause nephrotic syndrome. NSAIDs associated with minimal change disease. Gold, basilamine, and penicillamine with membranous glomerulopathies. And lithium and interferon therapy with focal glomerulosclerosis. For history, the first sign of nephrotic syndrome in the pediatric population is usually swelling on the face. This is followed by edema of the entire body. Adult patients can present with dependent edema. Frothy urine may be a presenting symptom. Tiredness and lack of appetite are common features. A thrombotic consequence, such as deep venous thrombosis of the calf veins or a pulmonary embolus, could be the first indication of nephrotic syndrome. Whereas for physical exam, edema is the most prominent feature of nephrotic syndrome, and in the beginning, it develops around the eyes and legs. Over time, the edema becomes generalized and leads to increasing weight and the development of ascites or pleural effusions. Hematuria and hypertension may be present less frequently, although these are more prominently seen in nephritic syndrome. For investigations, urine tests. Nephrotic range proteinuria will be apparent by 3+ or 4+ readings on the dipstick. Urine samples over 24 hours and proteinuria is diagnostic. For blood tests, the serum albumin level is classically low in nephrotic syndrome. Creatinine concentrations vary by degree of renal impairment. Total cholesterol and triglyceride levels are typically increased. Serologic studies can be done to find out the cause. Other investigations are Cub ultrasound and renal biopsy. For treatment, it varies by etiology of the nephrotic syndrome. Minimal change nephropathy in adults usually responds to prednisone. In lupus nephritis, prednisone combined with cyclophosphamide or mycophenolate mofetil induces remission. Secondary amyloidosis with nephrotic syndrome will improve with the anti-inflammatory management of the primary disease. Diuretics, such as furosemide, spironolactone, and even metolazone, may be needed. Diuretic use may lead to volume depletion, which should be assessed by monitoring symptoms, weight, pulse, and blood pressure. Anticoagulation has been suggested to prevent thromboembolic complications. Hypolipidemic agents could be used. In patients with secondary nephrotic syndrome, such as that secondary to diabetic nephropathy, some medications are widely used to reduce proteinuria, such as ACE inhibitors and ARB. By reducing proteinuria, these drugs will lead to reduced intraglomerular pressure, causing a reduction in systemic blood pressure. There are a few terms for staging of nephrotic syndrome. Remission. Urine albumin nil or trace for 3 consecutive early morning specimens. Relapse. Urine albumin 3+ or 4+ for 3 consecutive early morning specimens, having been in remission previously. Frequent relapses. 2 or more relapses in the initial 6 months, or more than 4 relapses in any 12 months. Steroid dependence. 2 consecutive relapses when on alternate day steroids, or within 14 days of its discontinuation. Steroid resistance. Absence of remission despite therapy with daily prednisolone at a dose of 2 mg per kilogram per day for 4 weeks. And congenital. presenting within the first 3 months of life, and in these children, there is usually a genetic mutation. The complications of nephrotic syndrome include infection, hypocalcemia and bone abnormalities, hyperlipidemia and atherosclerosis, hypercoagulability, hypovolemia, hypertension due to reduced kidney function and fluid retention. Edema of the gut could cause defective absorption resulting in malnutrition, ascites and pleural effusions, generalized edema, respiratory distress, sepsis, peritonitis, thromboembolism, and failure to thrive. That's all for this video. Thank you.